everyone. The Assistive Technology Forward meeting. I'm just going to quickly go through all of these slides. I'm not even going to read them to you because we have done them many times, but feel free to go back and look at this information. But you are at the Supporting Students with Medical Complexities meeting tonight. And we have a lot of very rich information, and we're very excited for you all to be here. Our learning outcomes tonight are to understand the wide range of healthcare needs of homebound students, learn about Leni, who is a first grader in Madison Metropolitan School District and who uses multiple forms of assistive technology to learn. We're going to assess the benefits as well as some areas of improvement for including students with medical complexities. And we're going to examine how the pandemic has increased and improved student inclusion in the classrooms. I am Anna Cliff. I'm a program support teacher for AT in Madison Metropolitan School District. I'm also an AT specialist in OT, and I like to think I'm a very forward thinker. We also have joining us tonight is Carrie Stafley. She is the Director of Health Services in Madison Metropolitan School District, a pediatric nurse practitioner, and she previously worked as a palliative care nurse practitioner at a local children's hospital. We also have the wonderful and famous Leni Tell. She's a 6-year-old, a first grade scholar in Madison Metro School District. She's known as the best speller in first grade. She shares life with terminal and fragile diagnosis, but it's considered genetically modified by new treatment possibilities. So I'm going to let Leni share a little bit about herself.
Anybody want to join me?
Leni,
I want to. Me too.
can
Okay,
you
We'll have you go down the slide, and then we'll get
can you say who you are?
Get on in there, get it.
Uh,
And next, you're up next. Woo. See it, catch it? See it?
Can you,
Oh, see it?
Hi, butterfly.
I do.
can you say my name is Leni
Look, Max, it's right up there.
My name is Liani.
and how old are you?
Great job finding the surprise, guys. Check out this translucent
How old are you?
Mickey Mouse. And here's the really cool
Are you
part.
6 years old?
Look, it's our mystery
Hey.
chaser one. That
Right up
is
there.
such a
My name is
cool toy
Leon.
to get.
I'm 6 years old.
Woo, something cool surprises.
Yeah, I know, it's funny. How old are you, Leonie? Can you tell them how old you are? Can you tell them how old you are?
See you next time. Bye, guys.
Can you tell them how old you are? Let's take this away from me. Can you tell them how old you are? Yeah? Yeah? Can you tell them how old you are?
I
Uh-huh.
want
Uh-huh.
one.
We're okay.
All right. Thank you, Leni, for sharing. I'm going to get the slideshow back up. And we will also share a little bit about who Nicole Fritz is. That is Leni's mother. And she shares her life with Leni, who is medically complicated or has a medical complexity. She's an advocate and medical manager for Leni and a local mental health therapist. So we are very excited for you all to join us, and we will start with Carrie Stafley, who's going to share some very interesting information.
Hi, everyone. Thank you so much for having us. I'm just going to give a little bit of background about what's happening for our students that are school-aged around their healthcare needs. So some of the most recent statistics are showing like just under 50 or half or 40% of our school-aged children have at least one chronic health condition. And with that health condition, and that health condition could be something like asthma, diabetes, it could be other physical conditions. But with that, just with having one chronic health condition, some of those can be very complex and require continuous and daily management in regards to that, as well as also working to address potential emergencies that might happen. So say, for example, for a child that has asthma, they might have a mild form of asthma and just intermittently need an albuterol inhaler occasionally. And then we could have somebody that has severe asthma that needs to take medication on a daily basis and also needs to have an emergency plan when they become super short of breath and when to call 911. So that's about 40% of our school age children fall into having one health condition. But there is another subset of children, and I can go to the next slide, that have chronic health conditions, and they are actually given the title as children with medical complexity, or CMC. And so children that have medical complexity have significant chronic health conditions that involve multiple organ systems. So it means it could affect their lungs, it could affect their kidneys, it could affect their ability to move, it could affect their brain. And that only comprises about less than 1% of all our US children. However, out of that, they actually are the biggest users of our healthcare dollars in pediatrics. So they look to use up about 30% of all of our healthcare costs. But even more than that, about 50% of the hospitalized pediatric patients are children with medical complexity, and they account for 82% of the hospital days in hospitals. And so they are a big user of our healthcare system, which means that they're coming in and out of the hospital quite frequently to help treat and manage their medical complexity. In the past decade, hospitalizations for children with chronic conditions have increased nationally by about 33%. The one thing that I want to talk about, though, with medical complexity, that always doesn't include having issues with cognitive development. And as a matter of fact, many of these kids, if you actually were able to adequately test them, they probably have a higher than average IQ. And there's a lot of reasons. And I think Leni would fall right into this category, completely neuro and cognitively intact. And she spends a lot of time hearing communications and things happening with adults. And she has been exposed to adult style communication and behaviors and been in hospital settings and heard lots of different language. I always say when you work in a hospital, you speak another language, just like when you're in a school setting, education has its own language and terms. And so children that have medical complexity are actually often very smart and know more than the average child comparatively. And so just always keeping that in mind, just because they have serious medical conditions, many of them are still fully cognitively able to do what their peers are doing, or maybe even more than what their peers are doing. Thank you. Then if you look at that, the other really concerning factor is that these children can often get really, really sick. And when you look at that, they actually are the ones that are admitted to our pediatric intensive care unit. So not only do they have very serious medical conditions, but they can have life-threatening types of events that require them to be in an ICU level care. But the thing that's very different about pediatrics versus adults is that 97% of our kids that get admitted to the ICU survive, and they're able to be discharged from the ICU. That is not even close to what it is for adults. Our kids are very resilient. They are able to fight back. We have really good, strong supportive care measures. And for the most part, kids have not done the same damage to their bodies that adults have by impairing their hearts or liver and other things like that. When we look at the medical complexity, and the thing that is just really challenging is if you look in the US, we have 3 million children that have medical complexity out of about 76 million total in that. However, our rate of children that are being diagnosed or fit the criteria for children with medical complexity is increasing at a rate about 5% a year. That's exceeding the growth rate of how many children are being born each year. And so there are more and more children getting diagnosed or that fit in the category of children with medical complexity. So if you look at just in the US from 2013 to 2017, we had an increase of 600,000 kids in the US that meet the diagnosis of children with medical complexity. So a little bit, I work at Madison Metropolitan School District, and this is just kind of a little tiny snapshot of what we're seeing here in our district. In 2017, MMSD had just a few students that needed really high level complex care medical needs. So we had one student that required a one-to-one special needs nurse. We assign special needs nurses when they have some type of respiratory involvement. So it could be somebody that has a tracheotomy or is required to be on a ventilator or continual BiPAP. We had 3 students that qualified for a one-to-one medically fragile SEA. And that is probably a term that anybody outside of MMSD probably hasn't heard of. A lot of people just hear them called special education assistants. But we actually identified several years ago that there's students out there that need more than just an SEA, but they don't quite need a nurse. But we know that they need somebody who has more medical training and has the ability to be able to assess the child and be able to do certain level of medical types of treatment throughout the day to be able to support that child. And so for a medically fragile SEA, the child has to be so medically fragile that the same set of eyes needs to be on that kid all the way throughout the day to kind of assess how they make it through the day. Then we had 2 students that were on long-term homebound, meaning they were going to be on homebound probably for their entire lifespan or career at MMSD. So 1 student with a special needs nurse, 3 students with a medically fragile SEA, and 2 homebound students. If we look at a snapshot right now in 2022, we have the following. We have 4 students that require a one-to-one special needs nurse at school. We have 2 special needs nurses placed at our 2 high schools because they have multiple students with medical complexity. And we have 14 students that require a one-to-one medically fragile SEA. And we have 7 homebound students that are long-term, meaning they will be homebound for their entire schooling through MMSD. So when you think about those data and everything that I just shared, what are some things that surprises you about these statistics? If you want to just pop it in the chat, or if there's not a lot of people, you could certainly share your thoughts too. One of the things, it was interesting, before I used to be a school nurse in the early 2000s, and I left and worked at the Children's Hospital and started the pediatric palliative care program here in Madison and spent 10 years doing that. And then I came back to the school. And, you know, a lot of people are asking, like, why are the numbers increasing? Anna, you can go to the next slide. And so you can see that these numbers are increasing, but why is that happening? And so what we know is there are continual advancements in medical care and the things that we're able to do. So we now have increased survival rates for infants that are born prematurely. We have really, really good supportive care that children can be born earlier and and we could also have children that are born with various congenital anomalies or have chronic conditions, but we're able to support and treat those. We have lots of new improved treatments for acute illness, especially in intensive care. Like I said, you know, 97% of the kids that go into the PICU or ICU for kids, they're able to be discharged from that because we have such great care for our kids. And then when we look at it, one of the things that I recognized when I was working in the palliative care setting is just the immense work that has been done in clinical trials. We've had advances in newborn screening. So we're looking for certain genetic abnormalities like the one that Leni has. When years ago, that was not picked up on newborn screening, it wasn't tested for, and now it is. But there's been a lot of advances with genetic testing and DNA sequencing, which then has led to specific gene therapy that can actually alter the course of what could have been a terminal condition and actually provided a therapy or cured or stalled the effects of what they have. And we have lots more and better supportive care and palliative care The goal of palliative care is really to increase the child's quality of life and really try to make sure that they're supported through that so that they are able to live their life to the best of their ability for as long as they possibly can. And the other thing that I noticed when I was working there too is there's a lot more medical doctors and surgeons that are willing to treat and operate on children born with terminal diagnoses. So there's many infants that are born that have a terminal condition where before it was a 95% would die before the age of 1. And what started happening is some of the surgeons would like correct their cardiac abnormality or fix their heart. And what we're finding is just by doing that, these children can actually live longer. And so when I came back to the district, I saw the numbers and I said, I started having conversations with people about what we're going to start seeing in our schools. And we are definitely seeing more and more students that have chronic medical complexity in our schools, which is great and exciting. Anna, can you go to the next slide? Thanks. So when you look at that, this is actually a care map for a child that has medical complexity. There's a lot of different people that are involved in the care of children and really trying to make them live their best quality of life. This one might be hard to see, but in the lower right-hand side, those are all the health providers that this particular child has. And then right above that is the school environment. And on that, you can see they have special education aides, they have speech, OT, PT, nurse, district nurse, special ed teacher, special ed director, reg ed teacher, and adaptive ed teacher. And when I was looking at this, one of the things that kind of struck me is what was missing from that, because that's a lot of people that are in the school, but is really thinking about that connection to an engagement with their classroom peers. And how can we better do that? And then if we look on the next slide, this is actually Leni's Care Map. It's a little bit easier to read. It doesn't mean she has less care providers than that other person. They just put them in different buckets, but you can look at all of the people that Leni has in her life to kind of help her with her care and support. And the biggest buckets, again, are her healthcare, her school, and then her in-home support as well. So in Madison School District, when we're looking at our students that have chronic health conditions or potentially are qualifying for a disability through the IEP process, we really try to individually plan for those particular students. And so the entire IEP team will get together and they determine not only programming, but also what is the best placement in the least restrictive environment for these children, for these students. At MMSD, if we have somebody who does have a diagnosis of medical complexity and they're able to come to school, we support them either with SEAs, or if they are so fragile that they need one person working with them throughout the day, like I explained before. An example of that would be somebody like that has a complex seizure disorder and maybe has seizures all the way throughout the day. And maybe their emergency seizure plan has 6 different steps to it. They need different medications and different interventions depending on how their seizures progress. That would be a student that we would put a medically fragile SEA with. That doesn't mean we have a whole nother bucket of students that need one-to-one support or need all-day support, but they're just assigned what we consider to be a regular SEA. And so I'm not even including those numbers in our numbers from before. And then if we're finding that a student that needs some type of nursing level support or has a tracheostomy, or is ventilated or uses a BiPAP machine, they would be assigned a one-to-one nurse through the district. Then there's another bucket of students that have medical complexity where it might be too dangerous for them to even try to come to school, or maybe their medical status is so fragile that it is best for them to stay in their home. So we have a process, and I linked it in here, about how we determine the need for students that would require be qualified for homebound. And so one of the first things that we do is, obviously our nurse would get background information, but we need a physician statement stating the reasons why they would qualify for homebound instruction. And then our nurse will review all that. And we have some criteria on the right-hand side there that they would be able to meet that might require them to be able to stay home. And then we can determine that if it's a short-term or a long-term need. So a short-term need might be a student, like say that was in a car accident and maybe fractured their pelvis and they're not able to be mobile. And so we know maybe they're only going to be home for a month or 3 months time. And then we have our long-term homebound students, which maybe it will be years, or maybe it will be their entire time that they're at MMSD. Then if it is a student that has an IEP or a 504 plan, that's when we would ask the IEP team to meet and kind of review the criteria and really make the decision of where is the best placement for the student. And so this is our document that we use. There's links to different letters that we use and the DPI question and answers for school district and families. So it's a great tool. If you would like to take a look at it, you all should be able to have access to towards it. So once we determine that a student meets eligible homebound services. So prior to COVID, we would assign a staff person to be in the home for up to 2 hours a day to meet their educational needs. That would require hiring of a homebound teacher to be able to provide the educational service and goals, along with various related service providers that the student might need. And a parent is required to be present whenever any of our staff are there. Once COVID hit, that really brought along the need for the ability to be able to connect with teachers and students virtually. And it really opened the doors for our ability to use technology to be able to make that happen. So the next slide, Anna, talks about how really COVID changed things for us at MMSD. So with COVID, we had a lot of families that did not only want their child not to come to school, but they also didn't want people coming into their homes. And so we were trying to figure out how to virtually connect all of those buckets of people that fall in for either their educational services or their related services. Then what happened for our school district when we went to virtual, we actually opened it up for our children that had needed some type of special education services. And I was actually shocked at the number of parents and this was back when we didn't know a whole lot about COVID. And they really had students that we would have put in very high risk for potential bad complications or outcomes if their child got COVID. But many of the families were seeing, without the services that were provided at school, that their child was starting to regress. So many of our families chose to send their child into school while the other students were out virtually, because they said they felt like it was a very safe environment. During this time, our staff really became comfortable with Zoom, virtual instruction, and using all sorts of different technology. I will tell you, before COVID, the staff at MMSD were kind of uncomfortable with teaching through a virtual platform that maybe a parent might be along with the student watching them teach at home. There was a lot of uncomfortableness with the staff with that. And I will tell you, COVID just completely wiped that completely away. And so that really opened up a lot of opportunities for us to be able to make those connections through technology.